everyone. Welcome to our Hacks and Hopes in COVID-19 Lightning Talks. This is our second event of our second day of the One HealthTech Week. So we are very excited to have you all here. Welcome. My name is Alexandra Hernandez. I am a health economist and policy consultant. I will chair this event with my friend Karolina Mackiewicz, who is a project manager with a public health and tech expertise, and we are both proud members of the One HealthTech community. To give a bit of background, let me first start telling you a little bit about what is One HealthTech. So One HealthTech is a global grassroots community that is mainly led by volunteers. We are nearly 13,000 people contributing to this effort, and we expand over 10 hubs already. Our aim is to champion and promote better diversity and inclusion in health, care, life sciences, and health technology and innovation. We run meetup events and we profile unique and unusual people within the health tech space, just like all of us participating in this event today. We also promote learning and training opportunities. Our mission is to be a warm and welcome community that is diverse. We not just talk about diversity, but also sometimes we talk about it as well as part of our activities. Now that you know a little bit more about our community, let me start telling you about the One HealthTech Week. As you all know, we are all facing unprecedented times, and we have been forced to stay at home and self-isolate. And this has encouraged communities like ours who base their activities in getting together with people in person to rethink their activities and keep going. We have no other alternative rather than keep going. Our health tech hubs have therefore come together during this time and organized a One HealthTech Week. And this is mainly a range of activities that we will be doing and conducting between Monday, yesterday, the 11th of May, to the 16th of May. If you would like to join us and check around the rest of the activities part of our Health Tech Week, please do check our website. Our One Health Tech team is very excited to have all of us today united online. We have a range of speakers working in different countries and also in different settings. So we have a lot of diversity speakers today. I'm very happy about that. Our speakers will be sharing with us today a quick fire presentations on the pivots and hacks that they have all faced since the pandemic and the emergency started. We want to know more about all the difficulties and the challenges that they have also faced, but also the diverse opportunities that they can see during the current time. Each presentation of the speakers is going to last between 5 and 10 minutes, and they are scheduled to finish around 7 o'clock BST time. Each of the sessions, after we finished listening to our speakers, we will then go through a session of questions and answers, and everyone is encouraged to post their questions either in the time of each talk or at the end. My friend Paulina and I will be very happy to share those questions with the panelists once we have finished with the lightning talks. May I remind everyone that we will be using the hashtag HowHTWeek in case you want to share any Twitter. Please feel free to do it. Let me now give the microphone to my friend Paulina, which will be introducing the speakers that we have this afternoon. Thank you.
Thank you very much, Ale. Just to add on to that, when you're asking a question, you can tag a speaker or like say which speaker you would like to answer, or you can simply ask and then let's see who gets to answer that question. Let me start with introducing Christine Andrea Andersson. She's a CEO of Fit to Grow, and she's also the co-founder of the Women Leadership Hub. Over the past few years, she has moved on from the corporate world to the consultancy arena to work more with startups and organizations who want to move their game into the next level of leadership and organizational dynamics. She is a strong believer that we all have a superpower inside of us, and only through inclusiveness and welcoming environment can unleash that superpower and nurture it and grow. And I had a pleasure to work with Christine actually for a little bit over a year. So I'm really honored that you agreed to be our speaker. Thank you, Christine. Over to you.
Thank you so much, Paulina. And thank you for having me here. Today, when I was asked about this, I said, you know what, one word came to my mind is overwhelmed. And 2 months ago, we were overwhelmed. We were running in all directions, from meeting to travel to media to entertainment to just everything was running. And then in the midst of all that, I think we missed the meaning. What are we doing? Where are we running? And this is something that resonated a lot with me. So today, which is 2 months ago, since I have been sitting at home, there was another overwhelmed word that came to my mind, but in another way, because there is a new reality where what was predictable before, it became unpredictable. What was complicated became complex. What was robust before became questionable. What was structure became agility and flexibility. And what we used to call change, right now, it's sustainable adaptability, it's called. So with all that, I have faced some recalibration. We are recalibrating everything that we're doing. We're recalibrating how we work. We're recalibrating the way our friends, who do we want to be in touch with? Who do we want to talk to? We calibrate how do we want to deal with each other? What is really important for us? And this period has, this pause, like, we press the button, pause and stop, got me to the point where is my anchor? Where is our anchor? What is really important for us? What do we really value? Is it we value health? We value community? We value family? What does really matter? And those are the strong foundation that will guide our behavior, that will guide our choices. So knowing those values, naming them, and securing that we understand where they come from, make us more predictable for ourselves and for others, because we know how do we act, we know what's important for us, and we know why we do what we do, and why is that important for us. We know as well what to tolerate, what not to tolerate, and we set our boundaries right. And in that time, I think it's important to understand where my foundation and finding strong and keeping it that strong. The other point that came as well, that what we are facing is difficult. What we are facing is unprecedented, precedent. We haven't faced it before. However, from one point to look at is that we never start anything from scratch, because we have learned so much during our journey. Our journey has started all along. We have faced difficult situation, economical downturn. We have faced political unrest. Some of us, we have faced a lot of uncertainty. We have a lot in our backpack. It's about pulling those strengths, and it's about working with them, and we can create new solution, and we are able to face those circumstances with another lens, a lens of opportunity and a lens of basically optimism, rather than going into all black that we don't know anything. So trusting ourselves and knowing our foundation and our anchor is extremely important to stay connected. Once we are staying connected and we have our inner coherence, we are able to connect with others and see others more clearly. And one way of doing that is to do, I do like regular check-in with myself. How do I feel today? Be in touch with my own emotions, knowing them, naming them, without judging them. It's okay to feel distracted today. It's okay to feel unfocused today. It's okay to feel grateful today. And all those emotions, once I name them, write them down, then I start to see the trends. And then I start to be, okay, what helped me here to get out of that emotion? What helped me here? So you create your own graphs of what triggers those emotions and how to deal with them. And one thing to remember is that we human beings want to control. You know, I want to control everything, but in fact, we don't control much. I control if I'm thirsty, I need to drive, drink or something like that. But we need to remember what we really control is the way we react to things. And that's the way we respond, because this is something that nobody can take it away from us. And this is something that is really ingrained, that I decide today how to react to that situation and take action. And this is what I call self-management. So we have our self-awareness and then we have our self-management. And by being connected with those 2 points, we are able to connect with others. Right now is more than ever important. Because together we are stronger, together we support each other, together we feel that it's, you know, sometimes I feel, okay, you feel the same, then I'm normal. So we find that, you know, we normalize that it's okay to feel like this. So we are stronger to fight the stress, and we are stronger to fight everything we have facing us. So what I want to, once we do this, we are able to stay grounded, we are able to stay responsible. This is a tough journey. And everybody say that, you know, we're not going to go back to our old normal. And I'm happy for that. There will be a new one, but let's make this new one that is sustainable and purpose-driven, rather than to make it materialistic-driven, or rather than to make it individualistic-driven. And by that, let's go back to water again, you know, the empathy in us, the collective responsibility, the kindness, and the altruism. Today, if I wash my hands and I care about my hygiene at home, it doesn't help, because I will need to do it not only for me, I need to do it to everybody's health. And that's important. So let's keep on going. Let's keep on helping each other, because we need to know that when we are in our deepest, and when we feel really bad, there is somebody watching us and saying, she's inspiring me to keep on going. So let's keep on inspiring others, because they really need us, and let's keep us together. Thank you.
Thank you, Christine, for this inspiring talk. One thing that really stood out to me is the idea of recalibration after this pandemic. And I think this is something that our next speaker, Tana, will touch on, how we will recalibrate learning. Tana Wuliji is the team lead for the WHO Academy, which aims to support 10 million learners to achieve health impact by 2023. She's passionate, nerdy, and relentless, all things the health workforce, because there's such a huge shortfall in it. It's 18 million. She's worked in 15 countries, including Liberia during the Ebola outbreak, and prior to setting up the WHO Academy, she established the Working for Health program run by WHO, ILO, and OECD. To guide and stimulate the creation of 40 million new health worker jobs. Tana, are you with us?
I am. Thank you so much. Thank you very much for having me. I'm absolutely delighted. Yes, recalibrating, revolutionizing. So this is really for WHO a top priority for us. Learning is so central to everything we do and everything we can possibly achieve. It's really time to rethink that. I think we've come a long way. We have so much further to go. I want to emphasize a couple of things. First of all, many of you may not be aware how huge huge the health sector is. There are right now 234 million people working in the sector all around the world. And this is going to grow, this workforce is going to grow to 350 million people in 10 years' time. So that's massive in terms of numbers. Not only that, every few months, the evidence base, the science around health is doubling. So you've got exponential growth of knowledge, information, you've got an acceleration of guidelines, and yet it's still taking us more than 10 years to implement the evidence we already have. So what happens? The gap between what we know needs to be done and what is actually being done is actually growing. And this asymmetry is creating a lot of inequity. It's affecting our ability to really be responsive and to save lives. So this is something that we as an organization, we've been thinking very deeply about over the last few years, especially with our DG, Dr. Tedros is very much a huge champion for lifelong learning, and his stated goal is to revolutionize lifelong learning. So what is that exactly? On this screen here, you can see actually a little app we just launched a couple of days ago. So you're welcome to download that. It provides you some COVID-19 resources, all of WHO's guidelines, etc. So if we go to the next slide. Essentially what the Academy is trying to do is take the science of adult learning, utilize the full extent of technologies to support learning, and to allow us to use that combination to take the state of the art in the global health evidence and the guidance that we provide as WHO to provide a learning experience that's much more immersive, more personalized, that's tailored to your needs, that provides you the combination of things you need to learn. Many of us, I'm sure, over the recent years have picked up a new device. I'm not sure how many of us read the instruction manual from that device from cover to cover. And yet we often approach learning in that way. Death by PowerPoints, you know, very much knowledge-driven learning. We know from the evidence time and time again that it just does not work, but we keep doing it. We're addicted to it. So how do we turn it around? How can we actually have a blended approach, maximize the use of in-person learning where it matters, where it makes most sense, maximize the use of digital learning to allow people to learn in their own time, to jump to the chase, work on the areas they need to work on, recognize what they already know, and build on that and move forward. See it as an engine that moves from day to day to day. How do we assess that? How do we break it down to micro learning and give people credentials that mean something? What does a certificate of completion mean? Does that mean that someone's more competent? This is a really important thing. So we want to recognize competencies gained. How do we do that reliably, etc. Sometimes people just need a particular question answered before they're able to move on. We want to create capabilities within our system so that people can have a complex query search. It's like having your personal assistant dig out all the information for you, as well as providing you advice. And it's this combination of things that we think is going to lift adult learning into a new direction, and hopefully in a direction of stronger impact. We learn best together. We're humans after all. So how do we maximize the use of peer-to-peer learning? And how can we go beyond communities of practice and Q&A to really allow people to learn in teams so that people can practice and work on building proficiency on roles that they have to execute together? And it's by doing that that we can actually shift the ball in terms of impact and outcomes. So by bringing the science together, by bringing the technologies, we want to do this at scale. So as was mentioned, we want to be able to reach 10 million people. This is not just health workers, but also all of us. We take care of each other. We take care of ourselves, parents, children, family members, loved ones, etc. Some of us are also educators. Some of us are advising on policy. Whatever role we take, we will have different learning needs. So with the Academy, we want to understand the different hats that people wear and how we can support them in their different roles. So it's a fully rounded experience of lifelong learning. Next slide, please. So in terms of the ways in which we see the Academy being different, you can see them here on the screen. I won't go through them one by one, but I want to really emphasize one point, which I think is the most important thing. It's about co-creation. I think sometimes, often when we're developing courses, we're developing it from the perspective of here's what I want everybody to know. And with the Academy, we want to flip it around to really understand what is the problem that people are trying to address that learning can be a solution to, and therefore how do we design that learning solution to be most most useful, most impactful, and actually support the achievement of better health outcomes and greater performance. So this is why we really believe in co-design from the outset. And just to give you a little anecdote, when we were developing the app, which I showed you the QR codes on the first screen, we actually got feedback from 22,000 health workers from 178 countries. We first listened to them. What exactly do they want to know? What do they need to know? Where do they feel they have gaps? What are they struggling with? What are their pain points? How do they access information? And we saw that 90% of them are accessing information through their phones. And yet a lot of our guidance and so on is really designed for laptop use. So this prompted us down the path of developing this mobile app. And we really believe that we can only revolutionize lifelong learning if we work with everybody. So we are on this journey now. We're in the setup phase. The Academy will be launched officially in May 2021 next year. But in the meantime, we're working on prototypes. We're developing new courses. But one thing we absolutely see the power and value of is co-creation. So we want to stimulate, be part of this learning ecosystem. We have so much to learn together. We're looking forward to taking it to a new scale. And thank you very much for your time. And I'm happy to take any questions. Thanks again.
Thank you very much, Tana. I think the part about bringing the science and tech together, it's really something that's it's very important right now in this, especially in those times. And I think our next speaker, Karolina Mackiewicz, I think she's going to touch on that topic as well. But before I give the floor to her, let me introduce Karolina. She works as the events lead at MyData Global and is also an international project manager at the European Connected Health Alliance. Karolina has over 10 years of experience in public health. Her professional mission is to bring people together to network, collaborate for creating actionable solutions for MyData implementation. And since March, Karolina organizes bi-weekly MyData versus COVID-19 community calls that focus on showcasing ethical database solutions for pandemic. Karolina, here's your floor.
Thank you so much, Paulina, for the introduction, and good afternoon, good evening to all of you from around the world watching this and listening. And yes, I'm here to tell you something about the MyData approach, and also sending you the greetings from MyData community, because MyData is the international non-for-profit organization which is actually community driven. So I'm really happy that we can today connect also with the One HealthTech community. And the title of this session is the Hack and Hope, and of course we need hope today and in the weeks to come, in the months to come. We also need trust and trust in science, and trust in the governments, and all the different solutions that are being implemented to fight the epidemic. And of course, many of those solutions are based on the personal data, especially now when we hear about the exit strategies, whether the governments are presenting how we are actually transitioning to the new normal. The contact tracing app, symptom tracing app, those are part I think in most of the countries. I don't know a country that wouldn't actually consider the contact tracing app. And of course, with the Google Apple solution, this is something that is becoming global. And maybe Paulina, if you can change the slide, and I will move here and use the quotation from Harari for Financial Times. I think it was at the end of March, when he said that, and of course, like maybe one step back, with the implementation of the contact tracing app and different immunity passports, different solutions that actually have access to our data, use our data, connect our data, we are asking ourselves, like, is it too much? Do I want to share it? And if in the pre-COVID times you could have this like your private data, now you're asked to actually share all your information, not only like, you know, what do you eat, but actually who you met, where you were, with for public good. And this also might feel like, okay, is this the something right to do, or is it too much? And of course, some of the solutions implemented in Asia might also, you know, make us a bit like or raise some concerns like about the surveillance. And now I would like to the quote the Harari who said like that actually asking people to choose the privacy and health is the root of the problem, and this is the false choice, because we can and we should enjoy privacy and health. We can choose to protect our health and stop the coronavirus, not by instituting surveillance, but rather by empowering citizens. And Harari didn't say this about MyData, but this is actually what MyData is about. And MyData is the approach to processing and managing personal data that puts the person, the individual, in the center. And it doesn't mean that it says that the individual is the owner of the data about them. It means that the individual is in control of the data and has the the authority on and should know where the data is going to, who is using for what, and should also get some reward for sharing this data. And we are not talking here necessarily about the financial reward, rather about the the better service. And what you see here on this slide, on this image, is actually like the whole ideology of MyData. So putting the person in the center, individual as the point of integration, and something as we call human-centric control of personal data. And you might ask like, okay, so why is it so important? And here we come back to this issue of trust and the issue of hope. So we know, and we know this also from the other countries, that of course for all those personal database solutions to work, we need people to use them. And for people to use them, they have to have trust that their data is not being misused, that actually the governments are only using this piece of the data, this part of the data that they necessarily need, and nothing more for surveillance. And in case of for example, the data tracing app, we know that at least 60% of the population should use those apps for them to actually be useful. So if less people use it, then it doesn't work. And this was the case, for example, in Singapore, where the very expensive app being developed for actually months and years since the last SARS outbreak is not being it's not being used. So if I can get the next slide. And so this was about MyData as a concept, and also MyData as the international non-for-profit is working, as I said, is the community-based organization, and is also working towards the first sustainable and prosperous digital society. So to make sure that the people get value from their data, but also that the organizations understand that the ethical use of data is the only and the best use. And we stand for the three shifts, which are explained further in the MyData declaration. And they are presented here. The first one is from formal to actionable rights. So to make sure that all those rights that are being written in the law are actually working for us, that the consent is easy, the consent is ethical, and we actually know how to execute the rights which are granted to us. The next one, the next shift is from data protection to data empowerment. And this actually means that to empower people to be able to act on their data, to be aware what is happening with their data, where is it going, also to ask people to ask questions. And from closed to open ecosystems, this is also something where we actually see the need for data interoperability, data being shared between the different systems, like every day, but especially now, where so many people being locked at home actually lost the access to many services where they previously were asked to come to the office to sign a paper and so on. So this is, of course, not only about the data contact tracing apps, it's about all the different services and also the authentication services that will help us to get get what we need from the authorities, also the social benefits, for example. And yeah, the next slide. And I said it's the international non-for-profit and a big community around the globe. I greet you from Helsinki, where we are headquartered, but we are now based in every continent in 50 countries with the local hub in 25 countries. And the next slide. And if you would like to join, then yeah, please do. This is open for everyone, for the individual and for the organizations. And the next slide. Like Paulina said in the introduction, I organize every second week now, since actually the end of March, the community calls called MyData versus COVID-19. Something was lost from the slide. Actually, you can also join us on Slack, mydata.org/Slack, and we have the Corona Data channel, very active channel, where you can discuss different aspects of how the personal data is or should be used for COVID. And the next call is, which is missing here, is the 21st of May, and it's at 3 p.m. Central European time. So thank you for the opportunity to present you MyData as a concept and MyData as the community. Thank you.
Thank you very much, Karolina. I think the key kind of thing that I'm getting from here is to getting the, like you were saying about the contact tracing app, that it needs to be 60% of the people using it in order for it to actually work. So I feel like getting people together is really the key to fighting this pandemic. And I think this is something that Kath will also speak about. So Kath is the managing director of the Alderley Park, the UK's largest bioscience campus, and a key business and science hub in the region and UK nationally, and a part of Bruntwood SciTech and its network of innovation districts and science and technology communities. Kath has an extensive experience kickstarting initiatives that grow companies. Most recently, she was on the executive management team at Innovate UK. Nurturing talent is very important to her, and Kath has been a mentor with Mass Challenge UK, which is part of a global not-profit startup accelerator for entrepreneurs, and the Healthcare Businesswomen's Association. It's a pleasure to have you here, Kath. I'll give the floor to you.
Thank you very much. Thank you, Paulina. Thank you very much for inviting me here today. I'm really happy to be part of this week of celebration of our network. I think the brief for today was to talk about kind of COVID-19 and hope, and also how we've pivoted and risen to the challenge that's been kind of set down in our industry. And I'll talk to that for a few minutes. I have a couple of kind of slides which explain kind of the company that I work for and our place in the world. But I work for a company called Bruntwood SciTech, which is a joint venture between a property company, Bruntwood, and Legal & General. And it's the largest UK network of innovation districts spread across at the moment 5 cities in the UK. We're investing in life science and technology in the UK. And I suppose in a simple way of putting it is, we're providing, I suppose, a 5-star hotel for companies to grow and scale. And I'm on the management team of this organisation, and I lead the Alderley Park campus, which is in Cheshire. If you flick to the next slide, please. And I don't know if many of you know about Alderley Park, but basically it's the UK's largest life science campus, and it's in Greater Manchester. It's home to around 200 unique businesses and organisations. So, Paulina, can you slip to the next slide, please? I don't know if it's sticking off. Oh, wonderful, that's it. And that gives you a bit of a flavour of what we have and where it is, just inside of Greater Manchester. Next slide, please. And I think the key message is that we're, home to 200 companies and 3 research institutes, which Medicines Discovery Catapult, the AMR Centre, and CIUK Manchester. And I think my reflections really on working with these organisations in such a strange time is that it's a bit of a mixed bag. So there are companies on site who are, one-person companies right up to multinationals, and there's a real spread of experiences on the campus at the moment. There are companies that are in very difficult times, and there are companies who have seen a rise in business with coronavirus, really. And I think what we're doing is we've had one-to-one conversations with each of those 200 organisations to find out what their challenges are going to be over the next 3 weeks, 3 months, 3 years, and how we can support, whether it's access to business support, linking them into various government programmes, finding partners and finding investment. I think we have a close kind of connection with each of our businesses. And I think while there are many businesses in challenging times, I feel hope, because I've never been more proud to be working in the life science sector. If you think of the initiatives that are happening across the UK at the moment, not just on my campus, which I'll talk about that shortly, but if you think about kind of the what's happening in vaccines development at the moment, what's happening in terms of the infrastructure that we have for COVID-19 clinical trials, I think there's a real coming together of the various stakeholders and partners in the life sciences, and I just feel very fortunate to be working in that industry right now. And it's absolutely fascinating to see various companies coming together, working on their parts of the challenge. And I think also, there's also been a kind of uplift in business that isn't coronavirus related. Actually, I think that people still need to make medicines. The companies that we have on our site, many of them are a valuable part of the health and care supply chain. So absolutely are essential and key workers, and have really been ploughing on over the last 7 weeks. We've not shut our campus. Obviously, we are obeying government guidelines and however they're interpreted. I think you'll see that I'm at home today, and many of us are still working from home, which is challenges. But the operation is open. We've got scientists at the bench, socially distancing, but getting their experiments and their studies completed, because they all have a role to play in the health and care supply chain. Next slide, please. So we are home to one of the UK government's mega labs, the Lighthouse Labs, and I'll talk to that now. But I think that's a really interesting kind of story of cross-organisational collaboration that it's been great to be part of. So I've mentioned that we've got a number of organisations on the campus working on coronavirus. This is by far the biggest initiative that we have on our site. We have the Medicines Discovery Catapult on our campus. They are a technology and innovation centre established and funded by UK Research and Innovation. And they were tasked, as coronavirus hit the UK, they were tasked with coordinating the establishment of these test labs by UK government and Public Health England. And there are labs at Alderley Park, Milton Keynes and Glasgow, and it's all been pulled together and coordinated by the Catapult. And it's been great to play a small part in that government response to COVID-19. I just got a phone call, I think it was on the 19th of March, from the Chief Executive of Medicines Discovery Catapult, Chris Bloy, and just very speculative, just explaining what he'd been asked to do, and essentially kind of sounding me out just to see if we could accommodate him on the site, and whether we had everything to help pull everyone together and support that project. And within, I suppose, under 3 weeks of that initial kind of scoping chat, we had patient samples at Alderley Park, which we were processing for PCR. So we managed, it was just a phenomenal effort, really, to get that facility kitted out and up and running. And my organisation has a lot of property and laboratory expertise, and was able to kind of make that happen quite quickly, working through the night to get everything up and running. Alongside that, there was a national coordinated effort where UK universities and research organisations donated their equipment to this project. So universities around the UK donated their PCR machines. They were sent to either us at Alderley Park, Milton Keynes, or Glasgow. So that was going on alongside it, kind of sourcing the equipment and getting the equipment in the labs. On the ground, the whole project was coordinated, and logistics support was provided by the UK Army. And in terms of now that facility is up and running, the people who actually work there on a day-to-day basis are, I suppose, another army, an army of scientific volunteers from various research organisations and academic groups throughout the UK. We have people in that Lighthouse Lab who are taking a break from Cancer Research UK, University of Manchester, University of Liverpool, University of Kiel, to name but a few. There are very many organisations that I've often name checked there. There are also a number of private companies and public companies who have donated staff to the project. So I know we've been kind of profiling some of those volunteers. So I can say that we've got people there from Waters Corporation and many others. So I think it's been an absolutely fascinating story of the public sector, the private sector, charities, etc., kind of coming together to create this facility in record time, and now getting to the point where, you know, we were testing samples at scale, getting NHS workers back onto the front line, you know, now getting patients and families tested, and it's been brilliant to play a small part in that. Next slide, please, Karolina. We had a virtual tour through Lord Bethel a couple of weeks ago, and this kind of shows the inside, the fuzzy inside of that lab, and numerous kind of volunteers that we have on site. So I mean, I'll finish there, but I mean, it's just times are tough, and times are tough for a lot of people. But I think my key message is that I feel very proud to be part of the UK's life science industry. I'm proud that my team has played a role in this project, which has been a coming together of various different people, different organisations, all putting their commercial priorities to one side, and the driver really has been on working towards this national testing effort for coronavirus, come hell or high water, and it's been great to play a small part in that. I'll finish there.
Thank you very much, Kath. It was very uplifting to hear that, and this is something that I personally also take great joy seeing this, like how communities and people are coming together, people are volunteering their time and resources for the greater good, and I think it's just fantastic to watch. Before I introduce our next speaker, I would like to remind everyone that you can start putting down your questions in the Q&A chat function. So you don't need to wait until the end of the session. I think if you have a question now, just put it down. I think it can slip people's minds easily. You can either direct it to the specific speaker, or you can just ask openly, and then whoever would like to answer that question, then we can give it to them. So I think I saw some coming in, so great job. Please keep that coming. And then without further ado, our next speaker, Claire Thompson. Claire is an award-winning scientist, strategist, and storyteller. She is the CEO of Agility HealthTech, a healthcare consulting and communications firm, and entrepreneur in residence at the University of Cambridge. So over to you, Claire.
Thank you very much. It's a pleasure to be part of such a prestigious panel. So thank you very much for the invitation to contribute today. So I want to talk about the mother of invention. And really, I wanted to shine a light on the inspirational responses across the clients that I work with, but also across the life sciences ecosystem. So we've gone to the next slide. So I want to talk about just three very simple things. The first one is in detecting coronavirus. And I can't commend Kath and the team at Alderley Park as part of the Lighthouse Labs on what they have done across that community. The volunteers that are staffing that and the infrastructure that has been put in place in such a short period of time is phenomenal. One of the teams that we work with, a little company called Microsense DX, they have within the space of a month taken an established detection technology for TB and converted that into a coronavirus detection kit, on a clinical trial, and showed that that can detect coronavirus in 30 minutes rather than 4 hours. So it can be run rapidly in parallel with PCR and with a number of other detection kits. And they're ramping up manufacture at the moment so that this can be used as quickly and efficiently as possible. So what we're seeing is that clinical studies are being approved more quickly. People are thinking, what have I got that I can apply to this need? And it's fantastic to see that, especially at this time. So the next piece is in connecting. So in collaborations, in making those necessary connections, not just in data, but in actually finding partners and groups to work with. And I think it's only fitting on International Nurses Day to highlight Ellen Half-Davis and her company Apparito. So they have partnered with Garmin to monitor at-risk cancer patients at home, to monitor, say, vital signs like their heart rate, their blood oxygen levels, to give very precise and early indications using a simple Garmin watch, and look at whether there are any early symptoms of coronavirus, and they can detect those quickly at home and give those patients the care that they need. And the last piece is in reflecting. So across the pharma and biotech community, we are seeing companies who are looking into their armory and looking at what assets they have. So have they got assets that are in the pipeline? Have they got drug products that are already out there that can be repurposed? So vaccines, antivirals that can be used and go into clinic very quickly to assess whether they can give a therapeutic benefit. We're seeing biotech companies that are screening their targets to see if any of those targets have potential to develop new molecules that we can fight against coronavirus. And we're actually seeing AI and data companies mining data sets out there. So Precision Life are a UK-based company, and they have a AI and machine learning model, and they've gone to the UK's biobank and actually find 59 potential drug candidates that can be repurposed and can be used for patients who have sepsis associated with COVID-19. So necessity really is the mother of invention. So it's driving innovation, faster collaboration, approvals, recruitment for clinical trials. I really hope that we can see that in the future. Can this pace be sustained post a pandemic? I really hope so. I really hope that we can break down some of those barriers and we can start thinking, rather than, as Tana said earlier, you know, we've got all of this science knowledge that's multiplying, but still it's taken us 10, 15 years to get new drug molecules to market. Should we be thinking in terms of innovation about what we have already? Can we apply that rather than going back to the start every time? I've also used the word mother on purpose. So what we are seeing in these times is actually female leaders have been exemplary in their handling of the coronavirus. So political leaders like Jacinda Ardern, even out to those who are scientific leaders. So Sarah Gilbert is the leader in the largest COVID-19 vaccine trial in the UK. We're seeing composure, compassion, competence. That's really shining out in women at the moment. One of my favorite mantras is never let a good crisis go to waste. I feel that these women are really doing that at the moment. I hope that I'm doing that as well, and I would encourage you all to do that too. Thank you very much.
Thank you very much, Claire. It was really great to hear the speed and the size of the response that people have given to this crisis. And I think it's really amazing to watch this. And I can't agree more regarding the female leaders. And I think this is something that we're also going to touch on a little bit later. One of our speakers also is going to talk about that. Before I go to the next speaker, please OHC week. Yeah, please keep on asking questions in our Q&A chat. So we're going to stay on the topic of innovation, and our next speaker, Shah, is an NHS clinician and digital health advisor, formerly director of digital development of the NHS. Sam has worked in digital health for the last few years, leading some of the national programs in England, and now advises a range of organizations in the UK and internationally. Please, Sam, I'll give the floor to you.
Wow, well, look, I'm really glad and lucky that you invited me today, especially having heard from all the other speakers so far. In fact, something Claire just mentioned there really resonated with me, especially around sort of your views on innovation and what it means. And something I've seen right now, clinically and in the digital community, is lots and lots of ambition around change, whether that's clinicians operating in a different way, clinical teams working together in a different way, or digital teams working with them to come up with new ideas. There's certainly lots of invention in the system, and that's hopefully helping with patient care. But we're not without our challenges, not only now, but before COVID. And I think what's happened is COVID has probably exposed some of the existing underlying fragility in the system, but at the same time has helped push the agenda on finding solutions much more rapidly. And that's involved new ways of working, but this has come at a moment in time, and the needs that emerge right now and the solutions that emerge right now during COVID may not necessarily be sustainable, and they may not be sustainable in the NHS, and they may not be sustainable globally. So we have to be willing to change in the next phase that follows after COVID ends and we start emerging from COVID, which hopefully won't be much longer further away. And some of these solutions that have come about have been digital. I've seen lots of examples of telehealth that have been used in order to create patient interactions and serve patient needs. There's lots and lots of examples of telemedicine, of individuals using monitoring devices and other ways of interacting with citizens to help deploy care. And then there's the issue around data. It was touched on a little bit earlier on around privacy and security of that data. And this has clearly been a hot topic for citizens, for clinicians and policymakers, especially as a result of tracing apps, both in the UK and globally. And the difficulty there is, when one thing in digital health doesn't necessarily go to plan, when it's not compliant, when that confidence starts to go from service users, from citizens, of course it has a knock-on impact on the other components of the digital health ecosystem, including telehealth, including telemedicine. So policymakers definitely need to do a lot more to improve compliance and improve the way in which they launch and build these products to help citizens. And they have to do this in a transparent way. So what about some of those needs? Well, those needs are split. They're split between citizens, ultimately, who are the users of services and the beneficiaries. Policymakers, who across the system are, of course, trying to help corral, collaborate, to organize, to meet the needs of citizens. But the healthcare workforce that are doing their very best to meet the needs of those citizens and have their own needs and burdens placed on them. The clinicians who are operating, who are treating patients. And of course, each and every single one of those is trying to work together to improve the outcomes for those people seeking care and ultimately reduce inequalities and inequities in access. And they're everywhere. The decisions have to be made, and sometimes the decisions have to be made rapidly. And they may not be the decisions we ordinarily make. I'll give you an example. If, for example, I wanted to communicate with another clinician, I would try and pick the safest channel possible to do that. But in these times, these difficult times, people might pick those channels that they may not ordinarily have chosen. For example, they might use messaging apps that are commonly used for social interaction. but they might not be the best products for clinical interaction. And the difficulty there is how do we go back? And is the citizen aware that as clinicians, we might be using products that aren't necessarily safe, that share their data in a way that they may not have chosen to share in a clinical instance, and of course, expose the system to risk? Now that risk might be accepted during the COVID period, but it may not be accepted in normal times. And what do we do to be transparent with our patients, our citizens, the users, that that's what's happening? And what do we do about the way in which the state responds to that? On the one side, the state might want to reduce the burden on clinicians to make their jobs and lives easier. On the other side, the state might be able to respond in a way that provides products and services that meet that need. Of course, the word digital is bandied around a lot. Digital health means lots of things to lots of people. But at the same time, we want policymakers not just to pick the shiny thing that appears, but pick the thing that fundamentally solves a problem, meets a need, reduces inequality, but allows us to deploy safe care for the citizen. And that may not always be the thing that is shiny, and it may not always be the thing that is easy. But during COVID, we might make easy decisions. What about telehealth? I certainly see that change a lot, very rapidly and very quickly. If I go back a year or two, when I was probably much more involved in the system, at that point in the UK and in England particularly, online consultations were probably at around a rate of about 0.5% or 1% of all of primary care interactions in general medical practice. But as at today, during the COVID period, we've seen that rise almost to 75% of all interactions being virtual in some form, whether that's video, whether it's remote, whether it's using email or something else. Does that mean that we're really treating the needs of all those people? Or is it only those people that have access to those tools, that can use those tools, that are accessing those facilities? What about all those that aren't accessing those facilities, irrespective of whichever background they come from? Is there an inequality there waiting to emerge that we haven't really addressed? And is COVID masking that? And on the other side, we might be congratulating ourselves to have boosted telehealth. On the other side, there are a bunch of users in the system that haven't had their needs met and may be experiencing suffering the ills of COVID or other things that we're failing to recognize. What about things like coverage? We might think that we have lots of coverage of digital health around the country through telehealth. We might think that suddenly we've gone from 15% to 95% overnight in perhaps England, but have we really? And is that utility? And is coverage a vanity metric that might suit policymakers and may suit politicians, but may not suit citizens who are the real end users of those services? And then what about other things like inequalities themselves? And I've touched on this, that citizens are fundamentally different. They access services through different channels. Have we really made channels available for all of those? And as we go out of COVID, we maybe go back to reverting to type and forget that we've got lots of inequalities that we need to address across society, irrespective of who those individuals are. Is there a risk that inequalities will widen because those people that need care the most may not be able to access it? The system could become overwhelmed. We may forget to address some of those that really need to be dealt with, such as those that may have language barriers, where digital solutions may not really have solved what it is they're looking for. And then as we start moving out of the COVID period, do we end up just accepting technology that was implemented for the need of COVID, the urgency, but it then becomes business as usual, the workaround becomes normal practice? And do we need people that can agitate and ask the right questions and challenge policymakers to do better, to do more? And that takes me on to inclusivity. If we're not inclusive in our decision making, bringing together people from a wide range of backgrounds, and I don't just mean gender or ethnicity, but those people that represent the very communities that we're trying to interact with. They could be single parent families, there could be ethnic minorities, there could be people that don't speak English as a first language. There could be all sorts of people that we need to include in the communities that are making decisions on digital health. But right now they don't exist. It's a very homogenous group that manifests amongst policymakers. Are we really seeing change happen? And after COVID, are we going to have the best decisions from the most inclusive group? Because I take the view that if we do have the most inclusive group amongst decision makers, we're more likely to deal with health outcomes and improve the health for everyone. So what are some of those innovations that we're now beginning to see from people who are thinking differently? Well, let's take research and development. We're certainly seeing that as an area that's having to change. Typical drug trials and trials around products can't take place. So I'm really enthused to see products that are supporting trials and studies using technology. And certainly the University of Oxford has been at the forefront of this, has produced something that everyone can use that could help improve uptake and adoption of trials, but deploy them in a different way using a digital channel. And it's great to see this. It's really interesting to see the use of sentiment analysis in healthcare to understand patient experience. I think this is great because this will help expose those communities that are suffering inequalities, and we can identify those from some of the experiences that individuals are having when they come into contact with health services. But we now need to get to a point where every board, every decision maker, everyone in healthcare takes patient experience much more seriously. And then there's telehealth and telemedicine. It's great to see new products emerge beyond the traditional products, not just those that connect citizens to their GP, but those that connect citizens to other healthcare professionals, such as their physio. And it's great to see those innovations come into the UK. So I think if we're going to move on from COVID and we're going to try and solve some of the problems in the system, we've got to focus on inequalities. We've got to focus on the burdens that clinicians face in the system and create sustainable products that help them, not just now during COVID, but beyond. And try and think of those things that will help citizens in a different way, whether it's through research and development, access to clinicians, or even their experience. But by doing this, we hopefully will get better outcomes. Thank you.
Thank you very much, Sam. I think these are some very important points and very important questions to ask going forward. I think staying on the topic of innovation, our next speaker is Daniel Zamora. He has more than 20 years experience in the life sciences sector and has specialized in entrepreneurship and supporting commercial organizations in introducing innovations into the healthcare market. He's also a co-founder of Health 2.0 Manchester, which is a local community in Manchester, UK, focused on digital health. And he's a senior manager at Health Innovation Manchester, leading on a NHS business support program for Cheshire East. Over to you, Daniel.
Thank you, Paulina, and thank you for the invitation for being in this event. So as Paulina mentioned, I've been in this health space for a few years now, and last 10 in innovation in the NHS, specifically in the northwest of England. And I'm going to approach this talk, and it follows nicely from the points that Sam has mentioned, which I utterly agree with. The acceleration that we're seeing due to the pandemic, but also the risks that we're carrying whilst we accelerate, and it's something that we've never seen at this scale and at this pace during my lifetime. So you can go to the next slide, please. So the first thing is the hot topic, I would say, probably third time this is coming up today, is the processing and sharing of data. And we have seen that in many places in the country, all of the big barriers that are presented around information governance and the time it takes for agreeing data processing agreements and data processing contracts has been dramatically accelerated. And this is on the back of the COPI notice that everyone can find on and it's publicly available. So that means that under a lawful basis of providing care to the population, healthcare, NHS organizations can now share data across, which is something that they have always had the chance to do from the technical point of view, but only in the last few weeks we've seen integration of care records at scale. So a few announcements probably are going to be made in the few next weeks, where now the clinicians that are seeing patients will have the access to the data across across regions that in the past they couldn't see. And that's with the hope that the pandemic is going to be put more under control, but also to protect the healthcare workforce and help them make better decisions. Again, the notice is valid until the September this year. So the big question that follows this is what's going to happen next. Is this processing and share of data going to be maintained beyond the pandemic, or are things going to be changing as people are providing their input into the rights and how the data is used? Following also from first second speaker, I think it was from Helsinki, the trust is a very important element, and I think governments that are that had demonstrated trust, like the Finnish government, where a lot of the Finnish citizens share the data, it needs to be handled with care. Now, next slide, please. The other acceleration that we've seen is all of the digital solutions that are being available for the citizens to use, many of them funded by the NHS. And this is part of something that we as an organization, Health Innovation Manchester, are supporting, where we supported a few of the commissioners in England, in Greater Manchester, to agree on those tools that could be extended and offered free of charge to the community. They don't need to be high-tech artificial intelligence, that they just need to fulfill the needs that the citizens have. And just to mention a few examples you can see on screen, but things like text messaging services for children, or emotional and well-being counseling for young adults and teenagers, things that are freely available that are going to help the population during these difficult times. And it's all fully funded by the NHS, which is also something that has been accelerated due to the pandemic. So it's well worth looking locally what things are available, as mental health is not the only space that has seen a bigger adoption of digital technologies being implemented. The next slide, please. Now, telehealth and teleconsultation, Sam touched on this. It's changing dramatically the way health is provided, and us, working in innovation for a while, this is something that we've pushed hard in the past around. Not everyone needs to be seen by a doctor face-to-face first time, and maybe some people do prefer to have a remote consultation, and if needed, a face-to-face consultation. But it's so dramatic the way this has happened that many of the clinical workforce has to be trained in how to operate this way. So this is just a snapshot of what's on the British Medical Association on the website, and how this is impacting the GPs and the clinical workforce around how to deal or how to manage those relationships in a different way. And we're seeing some of the software providers now improving their triage systems to be able to manage patients remotely better. Now the next slide, please. And then research, and research in the UK has been very, very important for the UK. This was a picture of yesterday's whilst I was preparing the talk, but this is a study that is using an app to being inputted by almost 3 million people that have symptoms. Today's figure is 242, I think, and this is run by King's College. But we're seeing some excellent examples of research due to the pandemic, and structures been reorganized to speed that research. The Health Research Authority with the ethics committees is streamlining all of the research, the National Institute for Health Research supporting all the COVID-related research. Locally in Manchester, we've established what we call a rapid research response group to help speed up the research that is undertaken at the local level. But I'm picking just this because an example of digital health and research, how the dynamics are changing, how digital health is enabling the collection of real world studies, and this is using technologies that we all use, but getting additional data that historically the clinical research don't usually get, which is the real world data. So we're seeing acceleration of those trends, and I think it's a very interesting time to see after the curve is flat and it's flattened, which of these things are going to remain beyond COVID-19. Next slide, please. And I think that was my talk. So I wanted to keep it short, just because there's so much to talk about on this space. But thank you very much. I'm happy to take any questions over the chat.
Thank you very much, Daniel. It was really great to hear from you. While I introduce our next speaker, Roopa Dhatt, I'm going to let my colleague Alejandra take over the screen share or share her presentation. So Roopa Dhatt is a passionate advocate for gender equality in global health and a leading voice in the movement to correct the gender imbalance in global health leadership. She's also a practicing internal medicine physician. She's determined to build a movement to transform women's leadership opportunities in health. Dr. Dhatt co-founded Women in Global Health in 2015. Today, Women in Global Health has more than 25,000 supporters in more than 90,000 countries and continues to grow. Dr. Roopa Dhatt is the executive director and leader of a global team with network of Women in Global Health chapters in every region. And yes, I think Roopa, you can share your screen. Let's try that option.
Great. All right. Thank you, Paulina, and thank you everyone for tuning in. So it's been really great to hear the fellow panelists really talk about the deep science and also the mentioning of broader inequities and the importance of having inclusion and diversity. So I really do appreciate that that's been a theme that has been running throughout some of the conversations in this community that's really looking to advance science, tech, and the much needed response in COVID. So I'm just going to switch over to the screen. Give me a few seconds to technically make this work. And okay. All right, wonderful. Are you, Paulina, seeing this on the screen now?
Yes, we can see it.
Okay. Great. So what I'm going to be focusing today's talk is really about a campaign that Women in Global Health launched in February, which we are calling COVID 50-50, a gender responsive approach to health security. And this really came out of glancing at how the pandemic was evolving and really in a way where we felt there was truly a need to bring a strong gender lens into the discussions that were taking place, particularly, one second, I'm just, great. So a little bit about Women in Global Health is that we are a global movement and a network of women and allies from all genders and geographies who are really fighting to support equity in global health for all genders. We work as a platform for all voices. We elevate the voices and visibility of those affected by gender inequities, and we really try to bring forward people that are the least heard and represented. So a lot of our chapters are based in lower middle income countries. we see ourselves as a catalytic force. And what we really mean by that is we position and connect ourselves really as agents of change when a conversation is not happening on gender. We are often the first to bring visibility to those issues, and also when representation is not gender equal or not diverse representation, we're also the group that brings visibility to that. And we also consider ourselves a strategic disruptor. It's something that we really embrace about ourselves, is that we want to see power and privilege be transformed, especially in systems and structures and norms, so that we truly have gender equal societies. And if we really don't have gender equal societies, then we're going to continue to approach the problems that we are facing, the ones that we're currently facing in COVID-19, but more broadly, when we're looking at health challenges, we're not going to have the best solutions put forward. And so this is where our global movement is throughout the world. We have a chapter currently in the pipeline in the UK, but as you can see, we have members from throughout the world, and really wanted to highlight that this is really important, that when we're talking about COVID-19, this is a universal virus that is not respecting borders, is affecting everyone regardless. And so when we are thinking about designing solutions, we really should be approaching our decision making and understanding the problems in designing solutions from that lens. And so particularly when we take a look at health specifically and global health security, it really relies on women. Women comprise 70% of the health workforce. We know specifically in COVID-19, the frontline response has been in many countries 90% women. This includes nurses. Today we're celebrating the year of the nurse, or this year we're celebrating the year of the nurse and midwife, but today is the International Day of the Nurse and the 200-year anniversary of Nightingale. And so it's really what it shows is that while women make up majority of the workforce, when you look at senior leadership and decision-making in the health sector, women only comprise 25% of leadership roles, whether it is ministries of health, whether it is particularly in the health security agenda, women are not well represented in task teams that are created on coronavirus or COVID-19. And when you look at even leading academic institutions, women are often not in senior leadership roles, and private sector has particularly mapping out Fortune 500 companies that work in health, less than 5% of those companies have women in the most senior roles. So there's clearly a leadership gap, and this does impact how we approach health. It impacts how health systems are designed. And when we look at global health security, we know that it is really the frontline health workers that are really the backbone of health systems. And so in response to what we started seeing as a global community, the Women in Global Health with our partners, is that gender was continued to be dropped when it really came to looking at the COVID-19 response. The first sign of it is when we looked at mapping out task teams that were being created around the world, whether it was the joint task team created by the World Health Organization, or it was national task teams that were the most visible ones, including in the United States and the United Kingdom. Gender parity clearly was not a priority. Often these task teams had less than 20% women represented. And this representation becomes quite important because of some of the points that were emphasized earlier, is that if we don't have diverse teams, and if we don't have teams comprised of people that understand the problems that we're trying to solve, we're never going to get to the right solution. So for us, equal representation begins with gender, but it is broader diversity. It is both racial diversity. It is also community diversity. It is also expertise and what we call expertise. And so including frontline health workers, such as nurses, community health workers, midwives, as part of that decision-making tree. And in response to that, we ended up launching what we called Operation 50/50, and this is still an ongoing campaign where we created a roster of women working in global health security. And we challenged the notion of what expertise really means and said, you know, we really want to include perspectives that have knowledge of what's happening at the front line. So what's really taking place when we are trying to implement the public health solutions that are made by policymakers. So including nurses, including community health workers, but at the same time, including policymakers that don't get as much visibility. And so within 2 weeks of opening up this call to nomination, we had nearly 100 nominations of women from all around the world, over 30 different countries. And now this is continuing to be an ongoing project, and Operation 50/50 has shaped particularly the public discussions. Many of the women have been approached to be featured in news interviews, included in articles, and we feel that that's really important in one, shaping gender norms. So the perception that women are experts in health security is often taken as a misconception that they don't exist. And so our list was really created to show that women experts really do exist. And then some of the other examples of task teams that we did mapping of, we're getting ready to release a review that's going to be covering over 50 countries around the world of task team composition. But in our first snapshot analysis in February, what we saw is that particularly these numbers were barely breaking 20% when you look at the variety of task teams that have been created. So clearly this is a challenge. And in the BMJ, the British Medical Journal, just last week, a piece was written about compositions of COVID and Corona task teams, and some of the aspects they looked at was not just gender, but also the transparency issue. As decisions are being made, we still do not know in many countries who are the people driving these decisions. Many of these task teams did not include civil society, community perspectives, and of course, the broader issue of who's really considered the expert that should be on these task teams. So these are all broader call to actions that we really encourage, especially the scientific committees, community to really look at. Is you have an opportunity to influence committees that are being created, whether it is within your own research institutions or whether it is in multi-center collaborations or whether it is actually how you are engaging with the national response. So raise the question of achieving gender parity, but going much further and truly having diverse teams. And then really, why all of this is really important is we feel that global and local solidarity are really vital in this emergency, and movements like ours, which work beyond borders, are key to confronting this global threat. As part of this emergency response, it is really critical that women are enabled as decision makers at all levels. And some of the other asks that we have launched have really been to show that gender responsive approach is really about making it everybody's business, that gender equality benefits all. We have 5 key points on this area, and one is that really now is the time for gender equality. We often hear it's an emergency, we need to focus on the immediate issues, lives are being lost, but actually gender equality is going to save lives, and without approaching gender equality as a core part of the response, we're going to actually lose many more lives. And so we really say that, without approaching this from a gender responsive approach, we're really missing out on the knowledge that women have, and women really are at the front line. They have the expertise. We just truly need to use that expertise. The second aspect is really at this point in time, we recognize that globally there is recognition of the sacrifice that health workers are providing, and we welcome the applause and the recognition of health workers who are mainly women, but we really need to turn this applause into action. And applause is great, but we need safe and decent work for all health workers, but especially women. We know that health systems have been established by men and been designed for men, often in time periods when women were not necessarily a majority of the health workforce, but now the default health worker is female. And we have to acknowledge that when there is a pandemic, not only is a health worker responsible for their original responsibilities as a health worker, but they're taking on new challenges for responding to the pandemic. They have increased responsibilities in their communities, and personally, they have increased social care responsibilities, whether it is homeschooling, taking care of children, taking care of elderly. And so what we call this is really the triple shift. And we need to acknowledge this when we are designing health systems, because if we're counting on women to provide all the healthcare, we also need to create health systems that are designed for them and have flexibility, have safe and decent work conditions, have the appropriate size physical protective equipment, which is often designed for male bodies and not for female bodies. And so there is a lot more acknowledgement of these issues, but we really call on the scientific community and, let's really make sure that we take this applause and turn it into true action. The other aspect of this is one which is not getting as much visibility is really the point about the unpaid work that is happening during this time. So the social care responsibilities, we already know the health sector depends on unpaid work. 50% of what women do in the health sector globally is in unpaid, which is nearly 1.3 trillion US dollars. And when there is a disease outbreak, or in the case a universal pandemic, we know that the unpaid work increases. And right now we are depending on unpaid work to really be our social protection, to be a part of our health system. But we know that this is creating weak health systems, and it is causing our health systems to really come tumbling down like a house of cards. And so in our Building Back Better response, this is the one issue which we really need to elevate and make sure that every person, regardless of gender, is being compensated for the work that they're doing, from social care to health care. And then finally, what we really want to emphasize is that, COVID-19 isn't really an equalizer. It's really magnifying long-standing structural inequalities between countries and within countries. We see this based on gender, but also race, ethnicity, socioeconomic, underrepresented communities. And as we, see these issues and more noise is being raised about these issues, we really must turn this noise into action, but also break out of the echo chamber. And some of the fear is that we'll go back, to the usual way of doing business. And right now we're operating under what we call the new normal, but in going back and opening up our society, we really should take the lessons learned from this COVID-19, but also lessons learned from previous disease outbreaks, and really make sure that we are creating gender responsive, equitable health systems that truly are designed by all genders and are made for all genders. And we see this as not only the right thing to do, but the smart thing to do. And without it, we're always going to be, setting ourselves up for future failures. And now we're really concerned about the current pandemic, but we know there is always going to be a next pandemic. So let's really address these deep issues. So thank you for your time, and really invite all of you to really join the COVID 50/50 campaign. We invite all of you to take our 5 asks forward, put in nominations for the Women in Health Security list that's still currently open, and it's an ongoing process. But please let us know if you'd like to collaborate on any of those 5 action items, because this is really meant to be a global campaign that we take forward together. Thank you.
Many thanks, Roopa, and the rest of the speakers for such insightful conversations. We are very proud to have a panel that has been very inclusive. We have covered a couple of wide range, actually, of topics already, and so a lot of food for thought now. Let's move on now. We are now on time in our agenda, so let's move now to the question and answer section. Some of the people in our audience have already shared with the panelists a couple of questions that I would like to share now with all of you. Someone in the audience has a question for Kath. Kath, there are so many volunteer and goodwill initiatives around with donation of time, skills, and technology and equipment. How is the sustainability of these initiatives being considered? Do you have any thoughts?
Right, no, thanks for that question. I think that, I mean, the first thing to really stress is this network is being delivered by the Medicines Discovery Catapult, but I can answer that question to the best of my ability. Really, it is being part of that wider group. I think that everyone has come together quickly to rise to that challenge, and a consequence, I think you're right, is that it has been a voluntary effort in terms of equipment and in terms of people. I think the focus really has been, I mean, given that, you know, we're not out of the woods yet kind of regarding coronavirus, just to kind of start hitting some of those numbers, and we'll all know that the government have set quite aggressive targets that they want, not just that network, but the wider UK testing capability to hit. So I think it's all hands on deck really, to start to address those short-term targets. But nonetheless, I think that the sustainability agenda is being addressed. I mean, I can't say more at this stage, because really the effort is, you know, to kind of addressing this short-term problem, and starting to chip away at that target. But they are looking at the long-term future for these centres and permanent resource. So I think that's all I can say at this stage. Is it is under consideration, because it is recognised that in pulling it together quite quickly, it's reliant on short-term contracts. So I think all I can say really is it is being considered, because there is an aspiration to a Hancock strategy to have permanent diagnostics and testing capability in the UK. So it's definitely being addressed, is all I can say really.
Fantastic, thank you. I know that Daniel and Sam also touched on sustainability ideas. Is there anything that you would like to add on this?
So from my view, it's a balance of risk and benefit, as always. So the only thing that I can say is when it comes down to volunteering, there's always an element of risk involved in managing the volunteers and accepting that offer of help. So it's a tricky one. So
It's Sam here, and I think this difficulty about volunteers in reality is much more complex, because as a service provider, I'm a clinical service provider, and I have volunteers who come into my services, and on the one side they're trying to do help, and they're trying to support your service, and the same exists for anyone else volunteering their service. The question is it sustainable? Can it be met? And quite often you tend to find is that you can't put the same demands and pressures on the volunteers, which means that then you're then left working out, can you really meet patient needs if some of them then can't support, can't attend? And the same happens for digital sort of technology providers, where they're offering some support, but it's very short term. So it's not necessarily sustainable. And I would say be cautious in that volunteering, both because of the risk to the volunteer and the risk to the ongoing service.
Okay, thank you for your views. Before proceeding, I would like to just inform that two of our panelists have to leave early because of other commitments. Tana from the World Health Organization Academy has left early, and Christine as well. Dr. Nelson Olim is here to respond to any question regarding the Tana's presentation on the application, on the app that has been done by the World Health Organization. Okay, let me proceed. we have a question for those involved with startups. So probably this will be more for Kath or Claire. Some startups are really booming in this space, but there is a general sentiment that investors are desperately trying to protect their own portfolios. So it's actually really difficult for entrepreneurs. What's your take on the investment space during COVID-19? Claire, do you want to start?
Sure, I can come in on this. I haven't seen any desperation around investors trying to protect their portfolios. What I have seen with the biotechs that I'm working with is that there isn't as much money around at the moment. You know, some investors can't liquidate their assets and therefore haven't got the money to invest. That doesn't mean that they don't have the appetite, they just don't have the funds available. It's a very crowded market at the moment. There's a lot of things that are focused entirely on coronavirus, which is it's natural at the moment, and therefore other areas of therapeutics or diagnostics are kind of jostling for position. But I still think it's a very vibrant investment space. I'm still seeing entrepreneurs being successful, a lot of money that's being raised. I'm absolutely not seeing that desperation to protect portfolios. Kath?
Yeah, no, I'm not seeing that either, really. And if I could add to that, I mean, I know the world has changed, and the world has changed very quickly. But in the first few months of this year, so first few weeks of this year, life science funds raised in excess of 5 billion to invest. So I think that, that prior to this, it was incredibly buoyant. And I think we've just got to be hopeful that there is some of the return as we move through these challenges. I'm not seeing any of that kind of protective mentality either in terms of the investment groups that we work with. I think one thing that would be interesting to keep an eye on is the public sector investments. So I'm thinking specifically the 750 million that was announced for Innovate UK to distribute. I mean, I think that it's a different type of investment, and it won't be. I don't imagine it's going to be. It is large. I mean, that they may choose to kind of dissipate that at a lower level through more companies. I think that we wait to see what that 750 million looks like. I think we all know at this stage it's going to be a breakdown between supporting existing Innovate UK companies with money available for companies they've not yet worked with. So it'd be interesting to see kind of the role of the public sector in this, because it has got a role, and there has been a commitment to Innovate UK outside of the other, I suppose, the other government initiatives that have been announced, like business rate relief and the bounce back loans, etc. I think there is some money set aside for innovation, and I think it's very interesting to see what the plans are for that.
Great, thank you. And a couple of questions from the audience referred to a cross-country comparison. So maybe it will be good to have Daniel's and Karolina's and Nelson's views on how our countries responding, the policy making of the countries responding to the current pandemic in terms of the data sharing agreements, the new regulations, or the new notifications that the governments are supposed to receive from patients. I wonder if you can also add something about if they how the different governments have socialized this idea. Is it going to be a matter of how the health systems are are formed, how they are responding, the different layers within the system? I wonder if you can give also your insights on the risk that this imposes on the data sharing challenges that each government will have. Would you want to start, Karolina?
Actually, I wanted to maybe give the floor to Nelson, who volunteered to answer this question live. Should we do it this way, or should I start?
I'm happy to reply.
Okay, jump in.
Thank you.
Thank you, Nelson, for joining.
I will add.
You're most welcome. No, I mean it's a very open question, and it's a very big world, and you don't have two systems that actually look alike. So you have very strong health systems being heavily affected right now, and you actually have weak health systems that are not being affected so much, for example, because just because the population, for 50% of the population is under 18, for example.
Yeah.
So it's very hard to say that there is some kind of rule or pattern out there. There is none. And the way the different governments and ministries of health are responding to the current pandemic is actually depends a lot on what kind of resources they have available, but what is the situation on the ground, and some of them are actually very limited by cultural factors. So I wish I had a proper response and say, well, you know, this is a trend that we see. I don't think there is a trend right now. I think no government actually wants to see their population suffer. I think I would take that as a given. And I would say most governments are actually relying on WHO guidance and recommendations than to build their own guidance and recommendations, which they don't need to be exactly the same. They need to be adapted to the cultural context. You need to understand that once WHO makes a recommendation, it's a generic recommendation. It's not like a one size fits all. They need to be digested and translated into the local culture and the local context, and even to the local situation. But our data so far indicates that most of the governments are actually, with a few exceptions, are actually following the recommendations. So we're all moving towards, as someone once said, we're not all in the same boat, but we're all in the same storm, in different boats, but we're all going in the same direction. So this is basically what I can say about it. Thank you.
Mm-hmm.
Thank you, Nelson. Karolina, over to you.
Maybe I will pick up on the data sharing and your part of your question when you ask how this might affect also the data sharing policies and practices. And well, on one hand, we might be like surprised or scared that like for example, the British government asked us to mandatory share our health data. At the same time, we know from the different studies that basically people are very happy to share their data for different purposes, under one condition, if they can trust that the data will not be misused. And this is as simple as it is, and of course very difficult to implement, as it's even though we have all the technology and we have all the solutions in place, we have all the things that actually make it all possible to stay anonymous and still share the data. And of course, there was also one question: what can be the side effect of the rapid policy making or rapid deployment of the different solutions? And I think again, like there's this news this morning I've read about the UK contact tracing app that was developed. Of course, millions of euro or pounds was spent on this. And well, it got critic and rightly so, being centralized, and now the government is moving to Apple and Google solution, which is not ideal, but is at least decentralized and following the safer protocol. So I would say that, of course, I mean, I think it all could have been like implemented smarter, like if only the politicians would like to really listen to. And of course, this is unknown territory. I totally understand that for most of the people out there, I mean, they've never even thought that they will have to deal with this, and this is, and actually also those solutions for contact tracing, they're being developed all the time, and something that was perceived as a safe one 1 month ago, it turned out later that it's not. But definitely I think that it's really important for all of us to work with decision makers and decision makers to work with us and to look for safer solutions from the start, like not to waste time and not to waste money. Just go for something which is good and that people will like to use. Because also, like, maybe one simple thing, like we all might be obliged to use one app or another, but then you can simply leave your phone at home, and what will be the use of that, right? So yeah, let's cooperate and let's make all this happen. But also, let's not be afraid of sharing the data. Thank you.
Thank you. Daniel?
Yeah, well, I'd just like to add that the sharing of data is a big topic. We could do a whole conference around it. But there's yeah, but exactly. But there's always the benefit of the secondary uses of the data, and it's something that we support for research as being an organization connected to the health system at many different levels. What we have done is we worked closely with technology providers that already have access to this data. In our case, we work closely with GraphNet to implement the sharing of the data and safeguarding the data and complying with the agreement of what data sharing contracts have. But also trying to push the secondary uses of that data for research, for learning, basically for the greater good. So I think I'm a backer of sharing data, and I'm a backer of sharing data with the government if you trust that government. Because what people that is linked to the National Health Service would want to do is to use that data for caring better for the population. So it's a big topic. I think we can spend all night just talking about that.
Perfect. Thank you, Daniel. Yeah, indeed, it's one of the core worries, I think, for most of the people when we talk about digital health. How do we assure that the information is kept safely? Okay, Sam had to leave us, but I'm gonna read one of the responses that he gave to one of the questions that was directed to him. If a COVID-19 vaccine was available tomorrow, where would you choose to implement it in terms of population type or country, and and would access to personal data be part of the deal? So Sam has responded, I think there is a risk that linking access to vaccines with reciprocal access to data will widen inequalities. Choices are rarely freely made, and individuals may choose to part with their data, not because it's the right thing, but because they felt forced to do so. Although I appreciate that the health economics in each jurisdiction will vary, and fundamental freedoms may not exist in all parts of the world. Okay, so I'm gonna move on to the last question, and probably, well, this might be probably for all the panelists. Is there too many innovation? Someone in the audience say, I am struggling to keep on top of everything. Are we all trying to help too much and could do with being more coordinated at the national level? What do you think if we start by Roopa? Roopa, do you have any views on this regarding leadership, for example? Leadership in women more specifically.
Yeah, so I would say that in the case of really leadership and innovation, we need much more of, so not the same challenge. It would be fascinating to be able to really collaborate with some of the tools that are being used to crowdsource right now for disseminating information, for actually disseminating who could be, potential speakers, who could be potential experts to be included. So right now, for example, Women in Global Health is using its website and uploading a PDF of, who are the experts, but it would be great for us to find partners that would like to make that into real-time availability, geographically relevant, divided into more categories. And then also linking some accountability components to it too. We noticed in our mapping of task teams around the world that most countries are not transparent about who's actually leading the response. Out of the 30 countries that we were able to get data, even in those 30, most of our data was collected by reaching out to someone that was working in the government or someone from that country. But when you look at the 193 countries around the world, that's still a very small number if we're only able to gather 30 through public public methods. So I think there's a lot more to be done on leadership. And then on the gender data gap, which I didn't spend a lot of time talking about, but both sex and gender data gap, that's another field we're seeing that data that's being collected is not being disaggregated by that. So there's really an opportunity for all innovation to really make sure that as data collection is happening, that it is truly disaggregated at the bare minimum by sex, but to really think about other factors such as age, such as professions themselves, which professions are getting more infections. Those are some of the points I'd say. So, all right, back to you, Paulina, and thank you for, again, inviting me for this session.
Thank you. Does anyone have any other final remark regarding if there is too many innovations at the time?
I'll come in on this one. As a scientist, I have to say absolutely no. Innovation is key, and we have to keep doing it. But I'm a big proponent of starting with an end in mind. So what is the problem that we're trying to solve, and is this the right way to do it? In terms of the leadership and coordinated efforts, it's very difficult at a time like this to have a top-down approach, so have that either global or national approach, and therefore that has slowed down some of the initiatives. And I've seen fantastic people working together either on a local or a regional level to bring innovations through to help each other. So no, I absolutely think we need to keep innovating, but in the right way, thinking about what we're trying to solve, and we need to keep helping each other.
I would agree with that. I mean, I think that the so what question still exists, like what will this do? Who will buy it? How will it integrate into the treatment pathway? How does it improve on existing treatment or technology? I mean, that those all still exist with coronavirus. And I think there's an element that actually the cream will still rise to the top. I think if you can answer those questions, you have more chance of your innovation being picked up. And yes, just to echo as well what Claire said, there are a lot of kind of regional efforts. I know the Manchester task force for COVID-19 is working to pull innovations through into the Greater Manchester population, and also, I mean, the government do have a portal where you can contact them, you can upload your innovation. So it's not a kind of centralised, regulated effort, but there are ways and means to contact government during this time, and they are monitoring that account, and they are responding to people.
Yeah, well, if I may add, clearly, I mean, I would say this virus has been the biggest driver for digital innovation ever, and for the digital transformation. I mean, so many. I was just thinking about the number of consultations that were done in the UK remotely just 6 months ago, and the percentage that it's done now. It doesn't mean it's sustainable, but innovation is not changing just the way we deliver information, is actually changing the process and on how we do it. And clearly, information overload is a 21st century problem that we need to start dealing with, because not everything that is out there is reliable, and not every innovation actually brings something good. Sometimes it's just a more complex way of doing something that is already being done in a more simplistic way. So I would say, I think we need to get ready, and we need to prepare our offspring also for this. Is how do you deal with these information overdose, and how do you learn to differentiate and to cross-check what is trustable and what's not.
Thank you, Nelson, for that. Just conscious about time. I'm really sorry that we can't cover all the questions now, but I have to say that we received a number of emails now from the audience asking if this session has been recorded, because people couldn't join or couldn't stay for the whole time. So we will come back to all the people that is listening and looking at us in the live stream session. I have no further comment. Paulina, is there anything you would like to add?
I think we touched on everything.
Fantastic. I would like to say thank you to all the speakers, to all the people who joined us today. Fantastic. You are now part of our community as well because you participated in this session. Thank you to everyone who made this possible. Stay safe and see you soon.
Thank you.
Thank you so much,
Thank
and
you.
good
Thank
luck
you.
with the week.
Thank you.
all the
Please do
sessions.
check the
Bye.
program if you want to join to other events. Thank you, everyone. Bye-bye.
Thank you.
Bye.
Bye. Bye.